Very warm greetings from Santosh Deemed Tube University, Ghaziabad, Delhi NCR. Myself, Dr. Rajiv Kumar Gupta, Professor and Head, Department of Prosthodontics and Crown and Bridge. First and foremost, I would like to congratulate the team Cynodent, their scientific committee, Dr. Ashish Chandra Pandey, Dr. Anmol Bagaria for their excellent effort to conduct this longest dental conference. So I congratulate them for such an innovative idea and execution. So the topic which has been given or assigned to me is a special techniques in complete denture. So I'll be covering this particular topic under various headings like definition, advantages of CD, conventional complete denture steps, technique in impression making, various techniques of jaw relation, special dentures, newer advancement, summary references. So I'll be trying to focus this with the basic conventional steps which is required for a conventional complete denture, and then few modifications of the special techniques for various clinical situations we might encounter in our day-to-day clinical practice. So starting with definition, we have a GPT-10 definition. So GPT stands for Glossary of Prosthodontic Terminology. So it is kind of a Bible for our us prosthodontists, because that gives us the vast level of the definition. So the latest GPT what has been introduced is GPT-10. So till now, 10 GPTs have been introduced. So as per GPT-10, it is a fixed or removable dental prosthesis that replaces the entire dentition or the associated structure of the maxilla or mandible. So we all know what are the various advantages of complete dentures over other implant supported or other surgical fixed dentures. So it restores functionality. So it improves the chewing efficacy of the patient, as well as teeth, as we all know, has a great role in the phonetics. So it improves the speech as well. Enhance aesthetics. So it supports the facial structure. So prevent the sunken appearance of a patient. Cost effective as we compare it with the implant supported prosthesis. So it is more affordable for our day-to-day patients of a middle class or a low socioeconomic status. Non-invasive, as no surgery is required. So for a like implant supported prosthesis, we have to go for a surgical procedure. So it is a completely non-surgical process, easily repairable and adjustable. So if patient is wearing the prosthesis and gradually it become loose, so as per the condition of the denture, we can think in the terms of relining or rebasing when needed. And also we can provide it soon after extraction. So one of the type of the complete denture is the immediate denture. So it can give us the immediate function as well as aesthetics to the patient. Coming to the fabrication steps for a conventional complete denture, I'll be discussing all clinical as well as the lab steps. So the first and foremost, we have to take a proper thorough history of the patient, clinical examination, followed by a preliminary or primary impression. So for primary impression, we are using a stock tray. So stock tray, as name suggests, it is a prefabricated sizes, different sizes trays as per the maxilla and mandible. So we have to select the right size tray, and then we have to go for a preliminary impression. So once we have recorded that, we have to pour the cast out of it using a type 2 gypsum product, that is your dental plaster. So it can be called as study cast if it is for a study purpose, or can be used for fabricating your custom trays. So custom trays, again, as name indicates, it is specifically designed or fabricated for particular patient. So also known as a special tray. So once we have fabricated a special tray, again, the clinical step, we have to do the border molding, and then the final impression has to be made. Once that is done, the lab processes, we have to do the boxing, beading boxing, and then pour the final impression to get the master cast or the final cast. That is mostly poured by your type 3 gypsum product, that is your dental stone. After that, we have to fabricate a record basis and the occlusal rim over your master cast, and then go to a clinical step in which we will be recording the jaw relations. So once it is done, we mount this particular jaw relation rims along with your cast onto the articulator and do the artificial teeth arrangement as well as wax up. So once that is done, we have to go to the clinical step in which we will be doing the wax trying. So we need to see whether the desired aesthetics or the phonetics has been achieved or not. So once that is satisfied by the patient and approved by the patient, then we can go for a final processing of the denture. That includes your flasking, wax elimination, packing, curing, deflasking, again finishing and polishing. And sometimes if we need arises, we can go for a re-verification of our vertical, so that we can have the right vertical dimension, so that there is no effect of processing errors. So sometimes when we are processing the denture, especially the polymerization shrinkage can lead to increase in the vertical dimension. So we can go for a re-articulation of the processed dentures, and we can go for a final vertical evaluation and then final insertion. And then finally, we have to do the post-insertion care for the patient. So these are the basic steps which has been included in the fabrication of a normal complete denture. So how do we decide that what kind of a particular impression technique has to be developed? So there are different approaches has been suggested by various authors. So one is your mecostatic approach, another is your mecocompressive approach. So as name suggests, mecostatic means we are giving very minimal pressure to the tissues. And when we talk about the mecocompressive, we are doing the maximum tissue displacement as it is in a function. And then we had a proper selective pressure, that is the most commonly used technique in our day-to-day practice, that was given by a Boucher. So we'll be discussing all those techniques in detail as well. So coming again, so this is just a step-by-step procedure I'm saying. So once we have fabricated the custom tray, as I suggest, as I told that it is specifically for one particular patient. So it fits only in that particular patient's mouth and it cannot be reused. We have to discard it after use. So once we have done the border molding and the wash impression is made, so this is how we get a proper wash impression, which provides excellent dimension stability and the final detailed reproduction, which is necessary for accurate prosthesis fabrication. So primary impressions, which is poured by your type 2 gypsum product, well, that is dental plaster, and then the final impression, which is poured by type 3 dental stone. Once we have recorded the right impressions, we pour the cast and we fabricate the occlusal rim. So then the next clinical step is jaw relation recording. So in that we have 3 jaw relations: orientation, vertical, and the centric. So I'll be discussing all these jaw relations as well as in detail. It is just a step-by-step procedure I'm telling for a normal complete denture fabrication. So once we have done with the jaw relations, we articulate on the articulator, and then we'd go for a normal teeth setting, wax trial, and once it is approved by the patient and checked by the dentist, we can go for a final processing. Coming to various impression techniques for making final impression. First is the technique which was introduced by Henry Page, that is your mecostatic impression. So as name suggests, we are not putting any pressure on the mucosa. So it is to record the tissues without compressing or distorting them, and it requires very light pressure during the impression making. Low viscosity material is used, such as type 1 gypsum product, that is your impression plaster. So it leads to the even material distribution. So this particular technique, which is actually not been used in regular practice nowadays, but it is indicated actually for your atrophic or a severely resorbed ridges, and it is contraindicated in a highly displaceable tissue that is also known as a flabby tissue. So if we have a flabby tissue and in that particular case we are trying for a mecostatic impression, it may result in a insufficient support for our dentures. Advantages: since we are causing a minimal tissue irritation or the discomfort, so it is very comfortable for the patient, improved denture stability and the retention in the challenging cases, like we said, it is indicated for your atrophic or a severely resorbed ridges. Disadvantages: very technique sensitive, requires meticulous attention to details, as well as there is a limitation with the material because that particular material is not been in use nowadays. Another technique which is regularly been used, all of you must have done in your clinical postings as well, that is your mecocompressive impression technique, in which we are using impression compound. So it is introduced by Geisy in 1910 and it is later modified by various prosthodontists, including Bouchers in 1950. So in this, tissues are recorded under pressure or the functional loading to mimic the tissue behavior during investigation. So what we are actually trying is that once patient is chewing or using the denture, what will be the forces on the tissue should be recorded in your primary impression. Only thing we have to make sure that when we are manipulating the material, it should not be too hot or too cold. If it is too hot, it can burn the patient's tissue. And if it is too cold, it will not have a sufficient flow to record the details. So the ideal temperature is 55 to 60 degrees centigrade to use this particular material. So step by step, again, first we need to select the right tray size from out of the stock trays we have. Sometimes we need to extend the tray as well. So it can be done with the help of the impression compound, or it can be done with the help of the cold cure acrylic as well. So once that is done, we have to break the impression compound into pieces and try to soften it. We have to knead it thoroughly so that the whole material is being softened thoroughly. Once that is done, we have to load our tray. And after that, we have to do the step that we have to preform it. So preform is that we are shaping the material in such a way that the final impression should be. So we are exactly preforming your tray. Then just heaten it. That's known as a glazing and tempering. So that bring the temperature to the level so that it should not hurt your patient. Then the placement of the impression tray onto the die or in the patient's mouth, removal of the impression, disinfection, and then remove all the excess material. And if needed, we can remodify the impression as well. So this is the final impression and the cast which has been poured from the impression. But the indications of this particular impression technique is then when we have a thick, well-keratinized mucosa and also when we have a healed ridges. Contraindication, it should not be used for a hypermobile or a flabby tissue, severe bone resorption cases because it will lead to an unnecessary tissue rebound. If we are putting too much of pressure on a flabby tissue and then when patient is in a relaxed form, that flabby tissue will rebound and will lead to the loss of retention and stability of the denture. So all these conditions are contraindicated for this particular impression technique. Advantage, it improves the stability during function, helping the patient with well-formed ridges, mimic functional stress during conditions, and also reduces the number of adjustment post-fabrication. Disadvantage, as I said, it can lead to the distortion of the tissue or the poor fit during rest. So when patient is not using, the tissue can rebound and can lead to the failure of retention and the stability of the denture. So it is not suitable for the flabby ridge or excessive highly resorbed ridges. The another modification of your impression compound impression is your corrective primary impression technique. So in which first we have to make a impression with a conventional impression compound. Then we have to create a grooves and over impression is been made with the help of the alginate to get the corrective primary impression. Also, we can modify the stock tray using wax. So this is an example where all this armamentarium is used. So we can modify the borders of your stock tray. And then you have to mix the alginate, load alginate in the syringe, place it into the sulcus area, load it on the tray, and place the tray in the patient's mouth. So this is how we are getting the corrective alginate impressions. Coming to the special techniques, if we have a flabby ridge. So the technique was introduced by Zafarullah Khan, also known as a window technique or a relief area technique. So relief of the pressure on the specific tissue. So can you see in the figure that we have this is the most common situation you will find in a clinical scenario that your maxillary anterior ridge is very flabby. So in this particular area, if we go for a normal conventional impressions with the impression compound, the chances of the flabby tissue rebound will be very high. So in this particular case, we have to go for a special technique in which first the primary impression is made with a alginate, then we have poured the primary cast. Over that, we have fabricated a modified special tray in which that particular area where we have a flabby tissue is not been covered with the tray. So this is how the tray with the relief will be visible in the patient's mouth. So the conventional border molding is done and the area of the flabby tissue has to be recorded with the help of some kind of a material. Earlier, we used to use impression plaster, but nowadays the light body polyvinyl siloxane material is being regularly used. So this is how once so can you see that border molding is being done for the entire area. Impression is being made for that particular area, but in the area where the flabby tissue was, the light body or the polyvinyl siloxane material, or we can use a dental plaster, is being injected. So in that particular area of the flabby tissue, no pressure is being applied. So we are recording the healthy area with a selective pressure technique and with the flabby tissue area with a minimal pressure technique. So it combines two different techniques. Also, we have a controlled lateral pressure technique, which was introduced by Jain in 2016. So again, it is done for the management of the flabby tissues in the mandibular region. So same process, it has been done with little modifications. We are performing the border molding and applying a low viscosity impression material. So ultimately, aim is that our flabby tissue should not get rebound. It should not get pressurized. We should not put any kind of the pressure on the flabby tissue because it is a distortable tissue. So we want to record it in an anatomic form. We don't want to record it in a functional form. Another sectional tray impression was introduced by Mehta in 2011. In that, again, they have made two different parts of the tray, which has been connected with the help of the magnets. So purpose is same, that in the flabby area, we don't want any pressure to be done. And other area, we have to recorded in a conventional manner. But ultimately, we want these two portions of the impression to be joined. So this is how the special tray has been fabricated in two parts, anterior part and the posterior part. Separate border molding is done, and later it has been joined with the help of the magnets. So this is how the final impression will come out. So the portion which is healthy is been recorded with the conventional ZOE, and the portion which is flabby has been recorded with the polyvinyl siloxane light body material. Coming to the techniques of final impression for the resorbed ridges. So conventional technique, we have a standard complete denture impressions. We are using a two impression procedure. First, we are making a primary impression, then fabricating a special tray, then border molding, then the final impression. But there are modifications which has been given for extremely resorbed ridges, which were first was the admix technique, which was given in 1997 by McCord and Tyson. It is the most commonly used technique in this. Basically, it is used for resorbed ridges to balance flow and stability. So in this, we are using combination of two different materials. One is your conventional impression compound, and another is your green stick in the ratio of 3:7. So when we talk about the 10 parts, 3 part is impression compound, and 7 part we have to take a green stick. So green stick, 7 parts allow you with a higher flow and a better adaptation, and impression compound gives you strength and stability. Another technique given by Winkler in 1985 is your functional impression technique. In this, we are recording the tissue contour under functional load. So it is ideally for highly resorbed or the flabby ridges. So we are actually mimicking the right functional load and recording the displacement of the tissues accordingly. So in the primary impression, it is taken with the alginate or the impression compound. Then we are fabricating the custom tray, which is having a spacer for your functional material. And then we are applying either a soft tissue liner or a light body. And patient is doing all the functional movement, that is your swallowing and speaking. So it's kind of a closed mouth impression technique. Then we have all green technique, which was given by Hartwell and Rahn in 1986. So it used only green stick. So normally we are using impression compound, but in this particular technique, we are using all green. All green stick compound means we are not using combination of compound or the green stick. It is the only green stick which assures better adaptation in the cases of the resorbed ridges. Cocktail impression technique, which was given by Praveen G in 2011. So again, it is a modification of the different technique, but ultimately what we are trying to record is the resorbed ridge with minimal or the functional pressure. So it combines multiple materials for better stability and adaptation, and it is used for highly resorbed ridges. So custom tray has been fabricated with the mandibular rest for support. So in that particular thing, for creating a functional load, instead of having a rims, they have created a rest on the mandibular denture base or the special tray, which is getting adapted to the opposite maxillary arch. So we are able to get the right functional load or the closed impression in this particular method. Another modified fluid vet technique, which was given by Littlewoe. So in that, we are having a special tray, which is having a window over your flabby tissue. So we are using a fluid wax, that is also known as a impression waxes. So we are using example of that is Iowa wax or Adaptol, which has been regularly asked in MCQs as well. So all these fluid waxes is been used to record your relief area. So it will not put too much of pressure. And finally, the area is been recorded with the polyvinyl siloxane impression material. So ultimately, goal of your light body is that it doesn't give pressure when it is recording the details. So this is how you box it, and then you pour the cast. One more technique which was introduced by me and my team in 2011. It has been published in Journal of Prosthodontics. That is again we have modified the functional impression technique, which has been already introduced by Winkler. But in that, what we have done is, instead of making a handle, we have made a full denture base, and we have created a space wherever we have a knife edge stitch. So wherever we don't want any excessive loads to be applied. Borders we wanted to record with a conventional manner, but at the resorbed ridge edge, at the crest, we should have it recorded with a minimal pressure. So in that, we are making a occlusal rim also. So that particular wax rim is helping us in the form of a handle of the tray. So all the border molding and the impression is been done with the putty consistency of the material. And then once we have achieved the right extensions with the functional impression technique, we are removing the wax strip, and we are also removing the putty in that particular area, and we are injecting the light body in the patient's mouth. So once we place this particular denture base with our right extension, we are getting the right stability of your mandibular denture base. So in that particular area where you want minimal load to be applied, the light body consistency of the additional silicone material can be applied. So we get the right impression. So we get all extensions as well as we are getting the right stability of the mandibular denture. So the final impression, as I said, we remove the handle and we inject it with the light body. And advantages of this particular technique is that we have having a selective pressure technique with minimum ridge resorption. So we have all the selective pressure technique formula to be used, but at the ridge where we don't want any kind of a pressure, it has been recorded with minimal pressure. So better adaptation for the flabby tissues, and it improves retention, especially the stability of the mandibular denture. So these were about the various different special techniques which has been introduced till date for your recording primary and the secondary impressions. Now coming to the jaw relations. First is your orientation jaw relation. So it determines the spatial position of the maxilla in relation to the skull and essential for transferring this relation to the articulator with proper occlusal alignment. So we can use either a phase bow transfer if we are using a semi-adjustable articulator, and if not, then we can use our conventional method in which we are using various reference points to orient our maxillary rim to the temporomandibular joint. So we can use fracture horizontal plane, we can use chamfer's plane, we can have a bipupillary line, so that we can use Fox plane to align the proper plane of your maxillary occlusal rim. So if you are not using a semi-adjustable articulator, if you are using a three-pin articulator. Then the next is your vertical jaw relation. We all know it basically determines the vertical height between your maxilla and mandible, and it is essential for your proper occlusion, aesthetics, and function. Because if you have not recorded the right vertical dimension, if you have done an excessive high vertical dimension, then it will lead to a very stressed kind of appearance of the patient. And if you have recorded it less, there will be a sagging of the tissue. So we have to have the right vertical dimension recording so that we can give the desired aesthetics and function to the patient. So types of vertical jaw relation, VDR, that is vertical dimension at rest, and VDO, that is at occlusion. So we measure these two and we make sure that there is 2 to 4 millimeters of the interocclusal space present between these two vertical dimensions. Methods can be used. Various methods are there. We can use physiological rest position, that is your Smongus method, which we routinely used in our clinical postings. We can use phonetics. We can use facial aesthetics as well as swallowing method. So these are various physiological methods which can be used to determine the right vertical dimension for the patient. And I said significance, we have to have the right vertical dimension, because excessive vertical dimension will look like the patient is having an overstretched mouth, and insufficient vertical dimension will lead to a overclosure. So it will give you a older look, or there will be more wrinkles. There will be no, the desired aesthetics will not be achieved. So coming to various methods for vertical, we can have the Smongus method, in which we are deducting the vertical dimension occlusion from vertical dimension at rest. That gives you a freebase space. Or we can have a Willis gaze also to measure the vertical dimension. Then coming the horizontal jaw relation, that in that we are recording the centric relation. So in that we have different methods. One is again, the most commonly taught and the done in our clinical postings is Nick and Notch method. And other methods are Needlehouse and Peterson method. So coming about Nick and Notch method, basically we are preparing the occlusal rims. In the upper occlusal rim, we are creating a nicks, and in the just opposite to that, we are creating a notch in the mandibular rim. So we record the mandible into the centric relation. We guide the mandible into the right centric relation, apply the light force to interlock the rims. So till we get the right vertical, and then we are getting the right centric, we keep verifying it. We keep verifying multiple times. Once we are sure that we have achieved the right centric, then we record it with the help of the interocclusal record material. That could be your ZOE or any elastomeric impression material nowadays can be used. Coming to the another method, that is your Needlehouse method. So in that, we are preparing the occlusion in such a way that we have adjusted the right vertical dimension, and in the upper rims or the maxillary rim, we are inserting the sharp needles, which will be exactly at the upper border of the opposing mandibular rim. Right. So once patient is in the right vertical dimension, we will guide patient in the centric relation, close lightly. Then this particular needles will keep a mark it will, whenever patient is doing all the eccentric movements, it will create a diamond shape marking on the opposing arch. So we keep doing it, we keep rechecking it, re-verifying it, and once we get it the right position, we confirm it, and then it can be locked with the help of the bite registration material. It is the needle house method is basically given by House and McGregor in 1933. Coming to the third method, that is Peterson method, which was given by Peterson in 1960. So in this, what we are doing is we are creating a trench in the mandibular rim, and that particular trench is filled with the pumice plaster mixture. So again, we are putting the rims back in the patient's mouth, asking the patient to do all the centric as well as eccentric movement. So this is how we are getting the mediolateral as well as anterior posterior compensating curves shaped into the pumice plaster mixture. So these are about here the horizontal day-to-day or the needle methods. But coming to the method which is used with the semi-digestible articulator. So we use tracers. So this is little beyond the scope of BDS. Mostly we are talking this with the postgraduates, but for a theoretical purpose, we should know this tracers also. So we can have two type of tracers. One is your intraoral tracers, another is your extraoral tracers. So as name suggests, intraoral tracers means all tracing is being done inside the mouth and we are not able to see it from the outside. So there are few advantages as well as disadvantages of one particular tracer. So coming to the intraoral tracers, the stylus is placed on the maxillary rim and the plate is on the mandibular rim. So once we have again established the right vertical dimension, we have attached the tracers, we allow patient to do all the centric as well as the eccentric movements, and all these movements has been recorded with the help of the tracers. The main advantage of intraoral tracers are, as compared to your extraoral tracers, that the tracing is more close to TMJ, so it is more accurate. But the another method is extraoral tracing, and the main advantage of extraoral tracers over your intraoral tracers are that you can see when patient is doing that movements, you can actually see on the extraoral tracer that how the movements are going on. So if there is any interferences or is there is any problem with the movements, we can actually catch then and there. But with the intraoral tracers, the visibility is not there. But the extraoral tracers has the center of rotation away from the TMJ, so it is little less accurate as compared to your intraoral tracers. So with the help of the arrow tip, we know that this particular point is the centric relation for that particular patient. So we can redo it, we can reconfirm, we can re-verify until we get the right vertical and the centric relation. We can perform the procedure again and again. So once we have recorded that, we have to do all the teeth arrangement and then we have to do the final processing of the denture. So now coming to special situations or the special dentures, the different kind of the dentures as compared to the conventional dentures what we can have. So one concept is your neutral zone in the complete denture. So basically neutral zone is the area where the forces of the tongue, lips and cheeks are being equilibrated. Means the forces from the tongue is counteracted by the forces from the lips and the cheek from the other side. So it is been said that if we try to adjust our teeth arrangement within that neutral area, means where the forces are being neutralized, we get the maximum stability during the function. So how we do that? So basically we record this neutral zone in the patient's mouth and we make an index out of it. So once we have recorded the proper neutral zone, it can vary from patient to patient as per the forces. So most of the time, this particular shape we get, we can see in the green color. So this particular shape we get for the neutral zone. So once we have got that neutral zone recorded in the patient's mouth, we make a matrix or an index, and then we have to arrange the teeth within that particular index. So this index guides where exactly our teeth arrangement should be. So once we have arranged our teeth accordingly, so it is considered that this particular arrangement of the teeth is in the area where all the forces coming over to your denture from either inside or the outside is being neutralized. So the stability of the denture, especially in the extremely resorbed ridges, will be much higher when we are following a neutral zone concept. Hollow dentures, which was introduced by Challian and Burnett in 1972. So it can be done for the patient in which we have a two increased vertical dimensions. So when we have a very increased vertical dimensions, the denture becomes very heavy. So to make it light, we can use this particular hollow denture. So there are, so this is how your hollow dentures looks like. So there are various methods by which we can actually fabricate a hollow denture. So first is your salt and sugar technique. So in that, when we are fabricating a denture, we place a layer of salt or sugar inside the denture before processing, and once the final processing has been done, we make a hole and we take out all the salt and sugar and we create a hollow space from that. Or we can have a putty index in which the silicone putty as a spacer is being inserted when we are processing the denture, and later we can remove that putty to make the denture lightweight. Or we can have a double flask technique in which the two separate denture halves are processed and it is being joined together. So this is an example how the salt and the paper technique has been used. So when we are packing it, we put a layer of the salt and the or the sugar, and then we process the denture. And once it has been done, it can be removed. This is an example of a putty index technique in which we are putting a putty when we are fabricating or processing the denture, and later on this putty we can make the hole and this putty can be taken out so that the hollow area will help in the making the denture hollow and the lightweight. And this is when we are fabricating two parts separately and then finally we are joining it together. Another special condition is your cheek plumper, which was introduced by Rosen and Gutmann. So in that, it is basically for the patient which has a very sunken cheeks. So even if we give a denture to the patient, it will not support the sunken cheeks, and patient will have a very old or the elder look. So in that particular case, the cheek plumper can be of remedy for that particular patient. So in that, basically these cheek plumpers are rigidly attached to the denture and it provides continuous support if it is of fixed type. And another type is detachable. So in that particular situations, this is an example of a detachable cheek plumper. So that cheek plumper can be attached with the help of the attachment of the magnets whenever patient wants to have a better aesthetics, and it can be removed. And we can have also fixed type in which we have a continuous support of the tissues with the help of a cheek plumper. Another special condition we can have for the saliva reservoir denture. So saliva reservoir denture will be required in the cases the patient who has been reported to us with the condition xerostomia, that is the lack of saliva. So in that particular patient, it is very difficult to wear a standard dentures because the chances of ulceration will be too high because of the lax saliva or the lubrication of the mucosa. The chances of ulcers will be much higher. So in that particular situation, we have to give some kind of a alternate option for the patient. So in that, we can have this saliva reservoir denture in which we can have a salivary substitute filled into these reservoirs, and slowly these reservoirs will discharge that salivary substitute in the oral cavity so that patient is more comfortable and is not feeling any dry lip or the mouth, and patient is able to wear the denture comfortably. Another special condition is our QC denture that was introduced by Wright. So it is the type of the complete denture which is designed to fit around the remaining very few natural tooth present. So in this particular situation, if you see only one molar is present and patient doesn't want to go for the extraction, so that particular tooth can give proprioception or the feel of the confidence to the patient. So to achieve better retention, stability, and proprioception, that particular tooth has been preserved. But if we go for a conventional denture, we will not able to get the right seal or the vacuum. So we have to go for a QC denture. So how it has been fabricated is that impression and the model preparation, we do it in a conventional base. But the QC denture, the specialty is that we are using a silicone gaskets, which we are applying it around the natural tooth. So we are getting a snugly fit dentures, which is providing us the desired retention as well as stability, and the proprioception is being preserved with the help of the tooth which we have not extracted. Another special condition that we can have a roofless denture, so maxillary denture without a palatal coverage, which is designed to enhance comfort, phonetic, and taste perception. But the biggest disadvantage with this kind of a flangeless denture is that it has a reduced retention because we are not having full coverage. We are not getting the right vacuum. We are not getting the right extensions into the vestibule. So definitely the retention will be too compromised. The stability will be compromised. So it is not suitable for very resorbed ridges without implant support. So most of the time we see this design when we have other mechanical retention and we are not relying on the conventional retention in the impressions. So another example of the flangeless denture, it is basically again for the situation in which a patient is having a very stretched look or when there is a prominent bone, especially in the maxillary anterior region. So in that particular case, we are providing a flangeless denture so that there is no protuberance of the tissues there. So it is designed without the conventional buccal or the labial flanges, providing a more natural and the improved comfort to the patient. Used for the cases where soft tissue support is unnecessary or we don't need it. So we have to make sure that it should be given in the cases when we have a very good ridge, because other areas are there to provide you the retention and we are not covering the buccal or the labial vestibule. Another special condition for the denture is your denture characterization. So we can have a patients with a high lip line. So we have to do some kind of the characterization. So denture should not look like denture. So it is always said that patients should not have a denture look. So to give that desired aesthetics, we have to have some characterization to be done or incorporated. So examples, we can go for a pink gingival characterization. We can have some kind of the staining in that particular area, or we can have some kind of a stippling or the root carving, or we can incorporate some veins so that whenever patient smiles, the soft tissue area which is visible looks as natural as possible. We can have an individual tooth characterization. We can do little, spacing, rotation, or wear pattern inclusion in the teeth arrangement, but that due consent has to be taken from the patient, that patient is ready for this kind of a characterization, and he or she should not feel that some error is being done during processing. We can have anatomical modification, like we can incorporate diastema or we can incorporate enamel cracks. All these modifications can be done in our dentures to suit individual requirements or the aesthetic needs. Even the denture bases can be modified by adding sometimes some stains of the tobacco or the melanin pigments. Coming to the newer technique, that is your biofunctional prosthesis. So BPS dentures, basically it is a patented system of a avoclar vivadent in which we are using a specialized tray for the primary impression or the final impression. In this particular method also, the functional technique is being used for recording the impressions. They have a special equipments to record the jaw relation. Everything is digitalized. They scan it. I'll be showing you a photograph. So this is how this thing. So they have a special trace which will make the maxillary and the mandibular functional impression. Then we have a setup to record the right jaw relation. They can scan it, or we can have it in a manual form also. So, and with the help of the injection molding, the processing, the main key feature for this particular avoclar vivadent system is that we are not going for a conventional packable methyl methacrylate system. In that, we are using a injectable methyl methacrylate system, which has better advantages over your packable systems. And then the latest and the most advanced is your digital dentures or the CAD/CAM dentures. So we have a digital scanners in which we can directly scan intraorally. It again its utility is yet to be proved, especially for your completely edentulous patients, because recording the right vestibular depth and the width is little challenging with the help of a intraoral scanners. But still, techniques is under process that we can fabricate the whole denture without having the conventional primary as well as the secondary impression. So we can scan intraorally, then we fabricated the denture basis, then we can scan the bite, and with the help of the CAD/CAM technology, we can fabricate a more precise and with a lesser processing errors. The chances, because all these denture bases are already processed, so chances of having a porosity or other problems are lesser in cases of your CAD/CAM denture. So we can have a more predictable results. But still, that the challenge that we are facing with the help of the intraoral scanner for recording patients' tissues directly in the mouth to get the desired extensions, it's a bit challenging. So most of the time what we are doing is we are making the impression, and when we want to fabricate a digital or a CAD/CAM denture, we are scanning the impressions to get the desired width and the depth of the sulcus. So these are the CAD/CAM dentures. So to summarize my lecture, I would say each technique, whether conventional or the advanced, plays a crucial role in ensuring a functional, stable, and the comfortable prosthesis. It is that choice of the technique depends on patient's anatomy, clinical expertise, and the desired outcome. So it's not that one particular system or one particular technique suits all. So we have to be thorough with all possible techniques, all possible clinical conditions, and which particular technique will be suitable for which particular situation. So it's not that your Zafarullah Khan technique will be applicable to all. So we need to understand that particular clinical scenario, and then what particular technique will be best suitable for particular situation. So these are my references. So I would like to specially thank my PG student, Dr. Manisha, who has helped me in compiling all this data for you guys. With this, I would like to thank the God Almighty, my mentors, because I always say luck stands for me is labor under correct knowledge. So I would like to acknowledge my PG guide, Dr. Padmanabhan, my mentors, Dr. Verma and Dr. Akshay Bhargava, who keep on inspiring me, guiding me. And thank you for your patient hearing. So the biggest disadvantage with online courses is this. So I hope my lecture has not been made you in this situation. It's not that boring. So with this, I would like to thank each and everyone, organizing committee, as well as the students. This is my mail ID. You can get back to me. Any doubts, any query, you can mail me anytime. I'll be replying it ASAP as per the time availability is there. Thank you so much.